tuning into this lecture. So my name is Louis. I'm one of the pediatric pharmacists from NUH. So I guess today you all know what is the topic about lah. I believe Miss Yichuan has already sent you all the handouts already, right? And as well as the slides. Maybe some of you can just let me know whether you have all the handouts already. Okay. Have, right? So it's my first time using this. Okay, great. Okay, yes, now I have a launch of yes. Okay, great. Okay, so I will start the lecture proper. And I do see that every one of y'all is here. Y'all totally have you all have 21 people in the class. Okay, so I will start my presentation now. Let's see. Okay, okay, let me see what I can see. Can you all see the slides? Okay, great. Okay, I'll just start the lecture proper. So in any event, if you have any questions, just post it in the chat. I will be able to answer that lah. Okay, right. So as mentioned, my name is Louis. I'm one of the I'm currently handling pediatric ward lah. So today we'll be going through this presentation called an overview of pediatrics. It's quite content heavy. So in the event, if let's say you find that you're a bit lost, you can actually put all your questions in the chat box, and I will try to attempt to answer them as much as I can. But this is not supposed to be a total exhaustive lecture. Like, for example, if you attend this lecture means you know everything of pediatrics. No, you probably take a lifetime to fully understand the tricks in pediatrics. So this is more like an introduction. And why is pediatrics so different from adults lah? Okay, so these are some of the topics I'll be going through. We'll be looking at why are they different, what is the difference in the pharmacokinetics and pharmacodynamics in pediatric children, pediatric patients. What are some of the special note to take note of, especially when we dose and calculate the doses in pediatrics, and some of the differences in the formulation comparing adults versus pediatric. They are a bit different. And I think vaccinations is something that we emphasize a lot in children because it prevents many diseases. So we'll go through that as well, and also some common pediatric poisoning and management. So in between, I will give your pauses because I understand it is quite difficult to stare at the screen for so many hours. So if in the event if you find that it's a bit too heavy, you can just put in a chat box. Like if you need a maybe 3-minute break, I can definitely give a rest as well. Okay, so let's all get started. So for the pediatric population, when we talk about pediatric population, it is a very diverse population, meaning that it can, at different stage of pediatric life, you will be termed differently. The most common classification is something that you can see from here. If you look at from birth all the way until 18 years old, you are considered pediatrics. However, if we zoom into certain portions of your lifespan as a pediatric patient, you will be classified as a neonate if you're less than 1 month old. However, we also know that sometimes babies could be born premature. So according to WHO classification, we use 37 weeks as the cutoff for preterm babies. Some of the hospitals, they use 38 weeks as the cutoff. So, but for the purpose of this lecture, we'll stick to 37 weeks. So if you are born less than 37 weeks, it will be classified as premature. Full term will be 37 to 42 weeks. Post-term will be 42 weeks and above. So, and thereafter, an infant will be in the range of 1 month to 1 year old. 1 to 12 years old will be classified as children. And after 12 years old, all the way until 18 years old, you'll be classified as adolescents. Generally, more than 18 years old, we will be considering you as an adult, but sometimes it may not be the case. So let's find out. So now we're zooming into the age definition of neonates. So it is very necessary to understand what is the correct definition for the proper age, especially when it comes to neonates. So these are some of the ages that I'm going to introduce to you. Now, the first one is called gestational age. So what does it mean? It basically means it's the total number of weeks that since the first day of the mother's last menstrual period all the way until birth. Why is it that we look at the mother's last menstrual period? That is because this is something that the mother can remember, something that is concrete, because we are unable to tell when the sperm meets the egg during copulation. There's no exact timing, we cannot tell, but the mom's last menstrual period is something that we can tell. So that's why this is actually noted and included in this definition of gestational age. As for postnatal age, PNA, or sometimes people call it chronological age, it basically tells you the time that's elapsed after the birth, meaning after the neonate has come out from the birth canal. Okay, and post-menstrual age, it's actually gestational age plus your postnatal age. So it's a bit difficult to understand by just telling you like that. So there is a very nice diagram over here. You can see that the first day of menstrual period, first day of the last menstrual period sets the beginning of the entire timeline. All the way until birth, that is classified as gestational age. From birth all the way to the date of assessment will be your chronological age or postnatal age. And if you add on these two together, this will be classified as post-menstrual age. Okay, so this is something that I mentioned just now, just put in a diagram format. So let's just do a quick practice on what we have mentioned just now. So baby Z was born at the 34 weeks gestation, and it is now 8 weeks old. So I believe this is also given, a handout is given to you, could be in a Google form. You can actually start filling up the different questions. So a reminder, PNA is your postnatal age, okay? Meaning the time spent outside of the mom's birth canal. And PMA is your post-menstrual age, which is your gestational age and your postnatal age added together. So what is the PMA? So was a baby Z born preterm, term, or post-term? Okay. And with knowing if you can find out what is the post-menstrual age, you'll be able to tell what do we classify this patient as under the pediatric population. Is it a neonate or infant or toddler or just baby? Okay, so I hope you're filling up the handouts right now. Actually, I cannot tell. I can't really tell whether you're filling up. But anyway, I'm just going to show you. So please fill up in 5, 4, 3, 2, 1. There you go. Okay. So this is your answer. Now, because baby Z is 8 weeks old right now, okay, meaning he has spent 8 weeks outside of the mom's birth canal, so that postnatal age will be considered as 8 weeks. So PMA is the addition of these two numbers, so you get 42 weeks. And baby Z was born preterm because we're using 37 week as the cutoff to tell whether the patient is born preterm or term. So in this case, it's 34 weeks, so definitely preterm. However, if you look at the post-menstrual age, right, it's actually at the 42 weeks already, which means we will actually classify this patient as an infant because infant is classified as 1 month to 1 year old. Patient is 42 weeks. So this patient is now classified under infant. Okay. Okay, so any questions you can put it in the chat box. I'll move on. So what makes pediatric pharmacy different? As I mentioned, it's a diverse patient population. That is because the one thing that's different from your adult patient is that children are always growing, okay, and there will be very, very different anatomical, developmental, and physiological changes that is happening in the body at different stage in time. So and because of that, at different age, it will require a very, very customized, individualized approach when it comes to their medications. And also, however, because children, there's a lack of drug research in children, simply because we don't routinely send our children to drug trials. If you're a parent, you probably won't do that. So because of that, right, there's a lack of published PK data, lack of safety data and outcomes data, especially in children. A lot for adults, not so much for children. And also, many of the drugs are not approved in children because they are not tested. So if let's say you're still using the drug for this population, we'll term this as off-label drug use. And also, there's also a lack of suitable formulations for pediatrics, because most of the drugs, majority of them are formulated for adults. So you have tablet form, you have capsule form. They are easily okay, as in it can easily be swallowed by your adult patients. But however, in children, we need to manufacture suitable drug formulations. For example, your suspension or your syrups. But the thing is, a lot of them we don't have a syrup for every single drug, so there is a lack of suitable formulation for pediatrics. Okay. So talking a bit more about off-label and unlabeled use. So this is for an indication that's not specified in the product license, because of they do not include these population in the clinical trial. So approximately about 50 to 70% of drug use in peds medicine have not been studied adequately to give you some form of labeling information. And because, simply as I mentioned, parents don't routinely send their young kids to clinical trials. So there's ethics involved. And because of that, there's scarce data in PK, PD, efficacy, safety data. And sometimes we don't even know what's the best dose in this population. And because of that, because we're using it off-label, we don't know whether it's safe. So is there an increased risk of adverse drug reactions when we're using it on them? We are not quite sure. And also, sometimes we need to know what is the therapeutic ranges of medication in this population. We have to create some form of arbitrary range or dosing for that. And because if, let's say, we are reluctant to use off-label drugs, right, we are also depriving them of potentially useful, beneficial medications in this patient. So these are some of the challenges of medication use in pediatrics on off-label use. Okay, so why is it important? So children are at a very high risk of experiencing medication error, because, as I mentioned, variations in weight, body composition, enzyme maturity, we'll talk about it more later, especially in the liver, and organ maturity. And because they're all customized, there's a lot of calculation involved. Some of them could be potentially complex. So because of that, high risk of harm due to med error. And a lot of tragedies has happened, reported over the years, when it comes to maybe insulin dosing, or when it comes to giving anti-epileptics in a wrong dosage. So that is some example. We will move on to the PK and PD of pediatrics. Okay, so this is a very nice diagram telling you what are the changes that can happen to a child. I will just briefly run through graphs A, B, C, D, E. So if you look at graphs graph A, it tells you about the changes in the metabolic capacity. So I believe in your course in this pharmacotherapy, right? You probably heard of this particular enzyme called CYP3A4. It is an enzyme that is found inside your liver that clears a majority of all the drugs that you put into the patient. So you can see this, the graph documents the activity of this enzyme when you are born, less than 24 years old, you can see that the activity is only at 10% of that of the adult version. And as you progress further, you realize that in 1 to 10 years old, it is almost exceeding more than 100%, near to almost 100%. So basically what it tells you is that as you grow older, your enzyme activity increases and matches to that of the adult enzymes. Okay. Implication is that it clears the drug better as you age. And if you look at graph number B, which tells you the percentage of total body weight, the changes according to the different age, you can see that at birth, the child's body weight is 80% water, compared to that of adult, which lies at around maybe 60%. So what it means is the baby is a bag of water. And what is the implication on this is that because some of your drugs are hydrophilic, some of your drugs are lipophilic. So in patients, when we need to dose drugs that are hydrophilic, in view of the higher percentage of total body weight that is water, we will need to give a higher dose in that sense in order to achieve good serum level. So this is one particular implication. And as for graph C, you can see the changes in gastrointestinal function. We'll take a hydrochloric acid production, for example. At birth, you can see that the percentage of activity is really low, and as it goes older, it gets better. That means more acid production. So later we'll come up, we will run through one question that involves the pH changes in the patient's stomach in the pediatric population. Okay, and another one is your renal function. So at birth, 1 to 2 days, you can see that the glomerular filtration rate, which is a good marker to look at when you want to estimate renal function, it is low and it goes higher and higher as you progress in life. So what it means is that when it comes to medications that are cleared by the kidney, you need to be very careful not to give too frequently because the clearance rate due to the kidney clearance is actually less. So the implication is that you probably have to dose it less frequent or even a lower dose, depending on what you're talking about. So as your kidney warms up, it clears much better. And sometimes, for certain drugs, for example, vancomycin, at the age of from infant stage all the way until maybe adolescent age, the clearance is actually even better than that of adults. So that is why for patients that are 16 years and less, right, we dose your vancomycin up to 4 times a day, versus in adults we are only giving 2 times to 3 times a day. So this is just one example. Now we move on to graph E. This tells you the integumentary development, talking about the skin. So if you look at your preterm neonate, the thickness of the skin is very, very, very low, and it actually gets thicker over the years. And also interesting to note that the perfusion on your skin is also very, very high. Just one example, if let's say, for example, if you have a scratch on your child's face, it actually takes a very short time for it to heal because of good perfusion. And also, everybody likes to touch baby skin because it's soft and supple. And that's because the water content in the baby's skin is very high compared to older adults when it becomes drier. So that's because it has high water content. And body surface area to weight, and you can see that it is very high because of the patient's weight is low, but at the same time the body surface area is much larger. This is a ratio, so it actually goes lower as well. So that is that's more like a summary of everything. Now we're going to go through one by one again. So for pharmacokinetics, it is defined by what the body does to the drug. And in general, there are 4 steps. We have the absorption, we have the distribution, metabolism, and elimination. Now, absorption, we're going to talk a bit more because there's multiple ways of absorbing the drug. So for gastroenteral absorption, which also termed as oral absorption, that is the most common route of administering the drug. However, there are multiple challenges when it comes to giving medication to children because there's gastric acid production. In neonate, your gastric acid production is actually less, which means your pH of your stomach, it's higher, it's more basic, okay? Later you'll see what's the implication. Also, gastroenteral transit time, meaning how fast does the stomach empty, it could be also slower in a child. Implication can cause more reflux issues. And we already mentioned drug metabolizing enzymes and drug transporters. They are not yet matured, okay, in a child compared to that of adults. And pediatric diseases of the gut, yes, as I mentioned, gut gastroesophageal reflux disease is could be related to the gastroenteral transit time as well. Okay, short gut syndrome is probably when your child is born and there is some defect in the integrity of your intestine requiring surgery. So your total gut length is shortened, and wow, that'll give you a lot of problem because that's where the gut is where your the main site of absorption of most of the nutrients. So if you have short gut syndrome, you probably have a lot of diarrhea going on and malnutrition issues going on as well. So something to take note of. And also your diet, it can also affect your absorption. What kind of a formula milk powder you're using, or are you using express breast milk? That's the most natural milk. Or are you introducing probiotics in the patient? So yes, all this can affect. And also, specifically for pediatric formulations, we term that as extemporaneous formulation, meaning that these preparations are not commercially available. That means we have to compound it from scratch using a different recipe. However, they are not exactly bioequivalent to adult formulations. So these are some of the challenges, or rather factors that can affect your gastroenteral absorption of the drug. Oh yes, so actually, as I mentioned just now, gastric acid production, it's elevated because not enough acid being produced in the stomach. So especially all the way until 32 weeks, your acid is still not enough. It only reaches adult pH at 2 years of age, so a long time to catch up. So the patients that are at risk are actually your preterm neonates, meaning your the acid in the stomach is just not enough. So what are the implications? Now, some of the drugs, the different drugs, some of the drugs are basic, some of the drugs are acidic. Why? That's because that's the nature of the medication. Is the depending on whether it has all the acidic functional groups or the basic functional groups on the chemical structure of the drug itself. So remember that ionized, and it is important to know that the drug moiety has to be in an unionized version, an ionized form, that it can diffuse through the bilayer in the gut for absorption. If your drug is ionized, okay, it has charges. And remember our cell membrane, right? It has it's a phospholipid bilayer. So your cell membrane is also charged. So if let's say you have charge and charge, it can actually repel each other. So making it more difficult for the drug moiety to pass through that membrane. So important, only the unionized drug moiety can diffuse across the lipid bilayer membrane for absorption. So in a more basic pH, for example, in the stomachs of your neonates, there's not enough hydrogen ions produced, not enough acid being produced. That's why it's called basic. weak bases, most of them will be unionized. Okay, and for that reason, if more of them are unionized, it is easier for them to diffuse through the lipid bilayer membrane, and that results in better absorption. Okay, and when you have better absorption, that translates to increased bioavailability. So that's why for drugs that are weakly basic, for example, your penicillin class medication, erythromycin, macrolides, this class of medication, if you were to give it to a preterm neonate, they have increased bioavailability compared to that of an adult. Okay. Conversely, if you're giving a weakly acidic drug, the bioavailability will be decreased because, remember, in a basic environment, the weakly acidic drugs will be in an ionized form, which means it cannot pass through the lipid bilayer membrane easily. Some of your examples will be your phenytoin, phenobarbital, ganciclovir, right? Okay, don't worry if you cannot get this later. We'll do a quiz and it will help you to refresh your memory on this. Okay. Okay, as I mentioned, gastroenteral transit time, the gastric emptying time, basically. So it is increased, especially in the first week of life. However, sometimes when you have when the drug dwelling time in the stomach is high, it allows more drug to be absorbed. Compared to, for example, if let's say you have diarrhea, the time that the drug spent in the stomach and the intestine will be less because you keep on having diarrhea. But if let's say the time spent inside there is increased, then you actually allow more drugs to be absorbed. So these are one factor to take note of. And as mentioned already, premature infants have slower gastric emptying than term infants. So it could implicate that the patient might get more absorption of the drug itself. Okay, so gastric emptying is delayed and irregular until 6 to 8 months of age when it's getting more stable. Okay, yes, we've talked about drug metabolizing enzymes and drug transporters in the liver. So, we mentioned before that the liver enzymes are not yet mature. Aside from the enzymes that's found inside the liver, your intestine also has a lot of transporters, and because there are some so-called these transporters aid the delivery of the drug from the intestine into the bloodstream as well. Some drugs will need specific transporters, but in the case of a young neonate, sometimes they are not mature yet, so that will result in a worse absorption, a lower absorption. And also in your gut, there's also bacterial flora, and they also help to they will affect the absorption of certain drugs as well. So if because the gut flora in the neonate is very different from that of the adult, simply because they take different diets, it can also affect the absorption. Okay, so what you can take home from this slide is that it can decrease the clearance of the drug reliant on these paths simply because they are not yet mature, whether we're talking about the enzymes or whether we're talking about the drug transporters. Okay, and we mentioned about short bowel syndrome and GERD. So as mentioned just now, short bowel syndrome, SBS, a decreased intestinal surface because you're cutting away a significant amount of intestine in you, so you have less surface area for absorption. Okay, and as I mentioned, diet. So introduction of feeds depends on what kind of feeds you're talking about. If your food is if your milk feeds are very high density in calories, it will actually slow down the transit time because it takes more time to digest them. And also take note that diet can also affect your absorption because of food-drug interactions. I think everyone is familiar with the use of ciprofloxacin and tetracycline together with milk, which contains calcium, that they can chelate in the gut, resulting in less absorption. That being said, the tetracyclines and ciprofloxacins are usually not used in children because of age contraindication. Okay. Okay, yes, another thing is pediatric formulations and administration methods. We already mentioned that extemporaneous preparations is not exactly the same as adult formulation. And although we make do by crushing adult formulations or mixing it with milk and apple, it can affect bioavailability. Not all medicines can be mixed with milk and or applesauce. It has to be checked with the pharmacist before allowing them to do so. All right, it's been a very long progress for this. So this is a very nice summary for oral absorption alone. Recap: gastric pH, it basically decreases as the child ages. Okay, meaning that the gastric pH gets more acidic when the child ages, and gastric emptying time usually it becomes better. Time is increased. Yeah, and they reach only similar to adults by the time they reach 6 to 8 months. Intestinal metabolism, it actually gets better over time as well. It was very low at birth, especially preterm, and it gets better. Same as the intestinal surface area, it actually gets more and more as the villi and as the cells in the intestine gets more mature, they get better absorption, and that's why the intestinal surface area gets more as well. Okay. Okay, other considerations for oral administration. So we also need to think of adherence of medication in child. So majority of them, they do very well because it is not the child themselves who takes the medication, it is the caregiver of the child that feeds them the medication. And usually they are quite prompt compared to that of an old adult patient. The adherence for children is actually very good if you have a caregiver. But as you reach adolescence timing, when you're at the rebellious age, teenage age, you don't want to take medications, the adherence rate might drop. So this was actually seen in our transplant patients, especially in their teenage years, when they just refuse to take a medication simply because either they are forgetful or because they know the side effect of the medication. That's why they kind of like cut down the usage or stop taking entirely, or simply just no reason. Yeah, so this is one comment I can give for adherence. As for ease of swallowing, yes, there are different solid formulations. You can have the tablets, capsule, sublingual medicines, oral dispersible tablet, granules, powder, enteric sustained release capsules or tablets. So these are the various formulations. And for liquid, usually it's suspensions or syrup. Okay. Also, sometimes when we crush the solid dosage forms, we do not know whether it's as efficacious as if we're giving the syrup form, because different drugs have different solubility. So as well. Also, I think most popular in pediatrics is the palatability of your medications. In adults, most of the time you're just swallowing the pill. You can't really exactly taste the taste, but if it's in a liquid form, you cannot run away. So we also need to take note of what are the excipients that we put inside in the formulation to help to mask the bitter tasting. Usually when I do this class, I actually allow people to try testing the medication in real life. But unfortunately, in COVID situation, I cannot bring real drugs to let you try. Yeah, some of the drugs, for example, your ibuprofen, Nurofen suspension, Nurofen syrup is very nice tasting. I remember, if I didn't remember wrongly, it is orange flavor, very sweet tasting. Zyrtec is banana flavor, and if you take our omeprazole suspension from the hospital, it is disgusting. It is salty and it's bitter, metallic tasting. Yeah. So imagine if your child has to take this every day, it's going to be quite painful. Yeah. Okay. Enough of talking about oral absorption. Do you all need a break? Let me see. I don't have any chat. Hi, is anyone still there? Okay. Maybe we take maybe 1 minute break, 2 minute break. Let's make it 2 minutes, okay? I'll be back in 2 minutes. Great, thank you. Okay, I think that's about 2 minutes. All right, we'll continue with the lecture. Okay, great, great. Thank you. Thank you, Andrew, for replying. Okay, I'll move on. Now we're talking about gastric tubes. So I'm not sure whether you have in your attachments whether you have seen patients on gastric tubes. But in the hospital setting, especially in the pediatric hospital, it is very, very common. And basically, it's because the patient could be having difficulty swallowing, or if they were to force to be swallowed, instead of going into the esophagus, it actually goes into the lungs, and that's dangerous because that will be aspiration pneumonia. So sometimes they will be given gastric tubes after assessment by the gastroenterologist. So the placement, different absorption sites will have different issues lah. So whether the gastric tubes enters through your nose, it goes all the way into the stomach, or it can go all the way to the small bowel. So if it's through the stomach, it'll be called nasogastric tube. If it's in the small bowel, it will be called nasojejunal tube. Okay. Now, if you have seen the tubes, especially in a very, very young kid, there is you look, the tubes are actually very, very, very thin. It's like misua, if you have seen. There is a risk of obstruction or clogging up of this tube lah. So if you're clogged up already, the patient cannot receive their drugs, they cannot receive their milks, then they'll be in trouble. So they have to come back to the hospital and change the tubes lah. But one consideration is that some of the drugs can bind inside the tube. So instead of being released in the stomach or the small intestine, it gets stuck into the gastric tubes. So we have to be mindful when we look at drugs. We have to take note of this factor, whether it absorbs to the gastric tube. And of course, it is very uncomfortable. In order to place the gastric tube from your nose all the way into the stomach, right? The outlet has to be hang around your ear, and then usually they have to plaster a tegaderm on the face. Some of the child can be allergic to the tegaderm and resulting in a lot of inflammation on the face. So it's very uncomfortable lah. and also whether the dosage form of the drug allows you to give medicines through the gastric tube, because since the tube is so small, you need to crush the tablet. Is your tablet suitable to be crushed or not? Does it have enteric coating? Does it have a modified release formulation that will be destroyed if you crush it? So these are some of the factors to think of when we handle medications to be given in gastric tubes. All right. Okay, we're still in under absorption. Okay, now I'm talking about the intramuscular absorption. So because there are multiple ways of giving the drug. So this is another way. So the thing is, in neonates, right, because of the muscle mass that they have is very, very, very little. If you were to give your medications through intramuscular route, it will be the muscles are not a lot, so the reduced muscle mass will decrease the drug dispersion, and also the muscle tissues are poorly perfused, not enough blood vessels in these muscle tissues, and that will reduce the absorption of the medication. And of course, the baby so small, the muscle so small, then you put a needle into the muscle, it's going to be painful lah. And also, there are specific volume allowances to be given into the muscle, because this is not IV, this is into the muscle. You cannot give too big a volume, if not your muscle will swell and it's going to be very painful. So these are the major areas where they inject the injection. Usually deltoid are for older children, because as you age, the muscle group gets bigger. You can give into the deltoid area, and usually it's less than 2 ml. For small kids, preterm infant, they'll use the buttock muscle, near the buttock rather. So this ventrogluteal side, or the vastus lateralis or rectus femoris, that will be thigh. So these are the areas that are popular for intramuscular injection, because the muscle mass is slightly bigger, okay, and it's not as painful. Okay, there's another medication, another site of administration is called the subcutaneous administration. So especially in this, certain vaccines are given subcutaneously. So they are injecting into the fat, not into the skin, not into the muscle, but into the fat layer, okay? And because fat is a very good reservoir site, a depot site, that allows the drug to be slowly absorbed into the bloodstream. So the way to get that done is to really pinch the fat, and then pinch, and then after that insert the needle. Unlikely to damage nerves and blood vessels. Compared to intramuscular injection, you might hurt a nerve bundle, but not so much for fat. And the volume is even less compared to muscular injection. It's the same maximum 1 mil. And intravenous administration is the more popular, more friendly site to give. Okay. However, there are limitations, limited by the line access. I'm not sure again whether you have seen little kids being asked to, whether you have seen doctors setting an IV plug on a small kid. It is very difficult to find the vein, because the child is so small, the vein is so small. You need a lot of skills to poke the patient. So if good, you have to poke the patients many times. It will kill the parent rather than killing the child, because it's so painful to watch, because they're always crying. So it's very, very difficult. And there are 2 types of lines. One will be the peripheral line, where the plug is inserted into the peripheral veins, okay? Whereas the central line will be, for example, your PICC line or your Mahuka line, where the line is directly injected into large blood vessels. So it could be, as I mentioned, PICC is peripherally inserted central catheter. That's where you insert the line through your veins, okay, all the way into the heart. The opening will be at the heart. So when you inject the medication, it goes directly into the heart, okay? That's where your big major blood vessels are. It can help to dilute the drugs that you're giving in. Okay, and also we need to take note of the infusion time, rate, and concentration of the drug we're giving. So in small children, there's always limited by the volume of the drug that we're giving. Yes, sometimes the drug can be given in this particular dilution, but you cannot give too much volume. It will cause the patient to have volume overload, okay, another problem. And also, there will be higher risk of administration reactions because they're more sensitive. Okay, so some drugs cannot be run too fast. Okay, you have to slow down. Okay, and also we need to flush the line so that the line will not get blocked. If you have a line that is blocked, you are unable to use it, then you're unable to give essential drugs to the patient, or you cannot take your bloods, okay, to test. So yeah. All right, now we're talking about the skin. I think just now we mentioned roughly about graph E, okay? So neonatal skin, it's very thin, okay? Uh, because the area is also very, very great and there's a lot of water content, it's very easy for the child to lose water. So higher insensible water loss. That's what the slide says. You cannot sense the water loss, but um, and also because child and young children, their body weight is mostly water ma. So if you're losing water so fast, you're losing your entire total body volume, and that could be dangerous because you might not have sufficient fluid going around your body to maintain your circulatory system. Okay, so what it means is that there's enhanced drug and vehicle absorption through the skin because it's thinner, and increased toxicity. So some of the examples could be your steroids. Okay, if you're giving a large area in a small child, there is an increased absorption, and because of that, there's increased toxicity. Right, now we're talking about the other area, the rectal absorption. So some of the medications they're given rectally could be because the child doesn't like the oral medications, or maybe it's because the child is seizing. There's no other way you can give them medicine except for rectal absorption, rectal route. So one of the example would be your diazepam rectal tube. What's so good about this is that when you give it through the rectum, it reduces the first pass metabolism. Like for example, if you swallow your drugs through the stomach, the medicines will be absorbed, but you will go through the liver first. And the moment you go into the liver, all the enzymes over there is going to metabolize the drug. So that's called the first pass metabolism. However, if you're giving through the rectal route, it will bypass this first pass metabolism. What it means, it means that your drugs will have better bioavailability. Okay. And however, when you insert things into the anus, okay, there will be high pulsatile contractions. They will want premature expulsion of the dosage form, meaning if you put in because you're stimulating that area, it will cause the muscles in the anal rectal region to contract, and then that's why it expels the dosage form. So when it happens, you reduce absorption. Okay, and also limited space in the rectum, so you cannot put too much volume there. Okay, so these are some considerations. Yes, as I mentioned, if the patient is not taking well orally, you have vomiting, or you have upper GI diseases, don't like the oral medicine because it's yucky, or patient is unconscious or seizing, so you can do that. And I mentioned as well irregular absorption because due to immaturity of the hepatic metabolism, as I mentioned, the first part effect, pulsatile contractions, and also blood flow. So erratic. Okay, now we'll talk about the lungs. Okay, we'll talk about medicine for inhalation. I'm sure you have seen inhalers before. We have the metered dose inhaler, dry powders or nebulizers. So if you're talking about medications that require coordination and proper technique, like your metered dose inhaler or dry powder inhalers, they might not be suitable for kids. So in order to make it easier, they use a space chamber and face mask. Okay, makes it that reduces the coordination required, and all these devices are initially intended for adult use, but they use it for kids and it works.
Okay, here's what I found online.
Sorry, don't know why my Siri is talking to me. Okay, Ken. All right, so let's conclude this. Okay, so practice question number 2. So baby Ming is a 4-day-old neonate born at 32 weeks. So the doctor wants to initiate oral phenobarbital. So explain why absorption of oral phenobarbital is different in an adult compared to a newborn premature baby. Okay, so to make it simple, I should give you blanks to fill. Okay, so pH of a gastric acid in neonate is more than that of adult. Okay, so later you fill it out. So only what kind of drug, is it ionized drug or unionized drug, can diffuse across the lipid bilayer and be absorbed. And phenobarbital is a weak acid and will be ionized in a more basic pH, thus more poorly absorbed. When is more poorly absorbed, the bioavailability of the phenobarbital will, okay, this is where you put in your answers, okay? So if knowing that the bioavailability of the phenobarbital will increase or decrease, okay, then do we use a higher or lower dose, milligrams per kg per dose for this drug in a neonate? Okay, so quickly fill up the handout form and we will proceed in 5, 4, 3, 2, 1. Okay, there you go. So your pH in the gastric acid in the neonate is actually more basic than that of the adult. Not enough acid, so basic law. And remember, only the unionized drugs can diffuse. Okay, so a weak acid will be ionized in the basic pH. So ionized, very difficult to absorb. Difficult to absorb, we have lower bioavailability. If we know that the bioavailability is low, then you need to give a higher dose for a kid to get the sufficient drug. All right. Okay, we'll move on. All right, distribution. So when you give a drug, the drug has to go somewhere, right? Okay. So some will go to the water. Some will go to the water component. Some will go into the muscle component. Some will go to the fat component. So if you look at the body composition, as I mentioned, when you're young, when you're first born, your bag of water mostly is water. So depends on what is the nature of the chemical structure of your drug, whether it's hydrophilic or whether it's lipophilic, okay, whether it likes fat more or whether it likes water more, okay. So it will have implications in the dosing. So as I mentioned, for water-soluble drugs, because your water content of the body of a child, a young child, a premature neonate, is mostly water, you have increased volume of distribution. So for water-soluble drugs, hydrophilic drugs like caffeine, gentamicin, benco, morphine, phenobarbital, they will have longer half-life because there's so much water inside there, okay? And in order to get a very, very nice concentration in the blood serum, you need a much higher dose, okay? Comparatively, lipophilic drugs, you don't really have a lot of fats in the child. So drugs that uses fat as reservoir like diazepam and lorazepam will have smaller volume of distribution. Okay. Okay. So the protein binding affinity also affects your drug concentration. So albumin binds to acidic drugs. Okay. And in your neonates and infants, the total plasma protein is actually less. So what happens is that if you have the same amount of drug, because you have less protein to bind, that means the fraction that is free, the active form of the drug, is increased, is higher. Okay, so this is one of the indication. And also there will be competition for binding sites as well. So for a child that is newly born, for neonate that's newly born, sometimes the bilirubin, I'm not sure whether you've seen like jaundice in a little baby who are just born. It could be because of the milk that they're drinking, breast milk jaundice, okay, or it could be because of the immaturity of the liver. So sometimes they still have a lot of bilirubin floating around inside the blood. And if you were to give medications that competes for binding sites with the bilirubin, right, it will release out or rather displace this bilirubin into the bloodstream, causing a spike in the serum bilirubin, and that could cause connectors. Okay, connectors basically means your bilirubin is very high inside in your brain, causing encephalopathy, brain damage. So some of the drugs includes your ceftriaxone and your sulfonamides like Bactrim. That's why we never give Bactrim and ceftriaxone to a neonate. Okay, it's contraindicated. All right, and also the cardiac output and regional blood flow. Your blood flow into the brain is actually increased. So and it results in increased permeability of your blood-brain barrier. Okay, yeah. So your blood-brain barrier, remember in your other pharmaco lectures, it's more like a sanctuary. It's very difficult to get through, but in a young child, the permeability of this blood-brain barrier is increased, and which is why it is easier to get a very good drug levels in your central nervous system. A lot of times when you went to the neonatal ward, they'll be given ampicillin and gentamicin, these two antibiotics, and they will get very good drug levels in your brain, okay, because of this increased permeability. Okay, okay. So drug factors, molecular weight, and water solubility can also affect your distribution. Okay, so for metabolism wise, as we mentioned just now, the metabolism activity is actually less in neonates, and it increases over time. Yes, lower at birth, and some genetic factors as well. So this brings into this area of pharmacogenomics. Certain enzymes are slightly more active in particular patients due to the genetic buildup. Like for example, warfarin. Okay, warfarin in Indians, we use a much larger dose compared to that of Chinese. We use a lower dose. Why? It's because Indians can metabolize warfarin much better compared to Chinese. Okay, so there are these kind of inter-patient differences lah, okay, due to genes. Okay, and maternal hormones can also influence, and even environmental factors, like for example, whether you're a smoker, whether you stay in a place where there's a lot of pollution, exposed to chemicals, it could actually change the level of liver enzymes in you as well. So if you're a smoker, you will have a lot of, you will actually induce your liver enzymes, so you clear your drugs faster, okay? Okay, so drug metabolic activity of specific pathway can lead to switching of primary DME pathway to another. So what does it mean? Switching of primary to another. Oh, so if let's say if you have one activity that is low, and if you're not able to clear the drug fast enough, you can switch to another path. Like for example, if your kidneys are not clearing very well, some of the enzymes in the lungs could take over. Okay, I think this is what this slide means lah. Okay, so there's some changes. Okay, now we come to elimination. Okay, so how are drugs eliminated from the body? So the kidneys are one of the major organs involved, and however, at birth, they are still immature in both structure and function. So as mentioned, we use glomerular filtration rate as an indicator of how well the kidney is working. So we already mentioned that it's directly proportional to the gestational age beyond 34 weeks, okay? And it doubles in the first 2 weeks of life, and it only reaches adult level when you're about 8 to 12 months old. Apart from this, there's also function in the kidney called tubular secretion. Okay, some drugs are secreted tubally, and because at you're immature, when you're term infants, the activity of tubular secretion is actually less, so it takes time for it to build up as well. It will only reach that level, adult level, when you're 1 year old. Okay, so it matters only if, let's say, your drug requires this tubular secretion function for clearance lah. Okay. Okay, so very quick wrap up of pharmacodynamics. What does it mean? It means what the drug does to the body. So development can alter the actions and responses of the body to drugs. So for example, drug receptor sensitivity, affinities, and also some paradoxical drug effect. If, for example, if you have, you know this medicine called Puriton, you know that it causes drowsiness in adults. But however, in a young child, sometimes it has the reverse effect. It actually causes alertness and giving parents more problem. Yeah, so question mark on that. And I think most importantly, there are certain drugs that affect the growth and development of the child. Because in adult, we don't really talk so much about growth because they are already adults. But in child, growth and development is very important. So the use of corticosteroids could stunt their growth. If we use the tetracycline, it can actually stick. It will cause a staining, yellow staining of the teeth and bones. Growth hormones can spurt their growth. Drugs that affect the appetite, causing them to eat less, and then because of that, short stature, malnutrition. So it can affect growth. So remember, peds, we have this additional aspect of growth that and development that we have to look into lah. Okay, so if you go into peds general wards, you can see that these are the main issues. Respiratory, you have the bronchiolitis, croup, pneumonia. Even in environment, social aspects, we have children coming in not because of medical issues, but because of social issues, because of parental abuse, child abuse. Okay, could be poisoning, or could be because of food disorder like anorexia. Then for GI, most of them come in with diarrhea, vomiting, and then they're likely having gastroenteritis lah, stomach flu, or it could be infection, or could be neurological in nature when they come in with fits, febrile seizures, or some or cardiovascular related. This is getting more and more common. This disease called Kawasaki disease, where it's an autoimmune disease where antibodies are generated in the blood that attacks the blood vessels, major blood vessels in the body, causing a lot of issues. So how can we tell? So for example, in this kid with biliary atresia, you can see that the tummy is very, very big. That is because of ascites. When you have do not produce sufficient albumin from the liver, and that causes a lot of water retention into the belly lah. Okay, Kawasaki disease, as I mentioned, is an autoimmune disease. Typically, classical symptom will be a strawberry-like tongue, okay, and also red lips, dried cracked lips as well. That's because the autobodies generated by the own immune systems are attacking all these blood vessels in this area. Okay. Okay, so to sum up, pediatric is not the same as young adults. They are not, dosage regimen is not just like half of that of adult. It has specific, customized to patient. And also in terms of drug contraindication, sometimes there is a age-based contraindication. So as mentioned, your trimethoprim and sulfamethoxazole, that's your Bactrim, is contraindicated in 6 months old. But I already mentioned to you, it's because it could displace your bilirubin, causing connectors. So that's why we don't allow that. And also promethazine in the use of less than 2 years old could result in respiratory respiratory depression, causing the child not being able to breathe and get a hypoxia. So that's why they are contraindicated. Okay, we are going to jump straight into dosing and calculation in pediatrics. So at this time, point in time, please get ready your calculators, okay, or you can use your phone. This will be quite interesting session. Okay, so in pediatrics, there are special parameters that we need to take note of that usually we don't take note of in an adult prescription. So we need to know what's the age of the child, whether it's how many days old, or how many months old, or how many years old. Okay. Weight in Singapore, we use kilograms. Okay, we don't use pounds. And body surface area, sometimes we use it more for oncology purposes when we're giving chemo or other drugs. And also we need to know what is the specific indication, why we are using the drugs for. Different indications will give you a different kind of dosing as well. And also it depends on the patient's pre-existing condition, whether the child has a liver issue or whether it has a renal issue. The dose has to be adjusted according to that condition. Right, talk more about it. Okay, so dosing by age. For example, your cetrazine, which is your Zyrtec, is very easy to remember because you just need to know what's the patient's age. Then you can dose accordingly. Very easy to use, very fast to use, but it is not always reliable because that dosing by age is for normal kids. Okay, so if the child is not catching up when it comes to their growth or development, it might not be appropriate. If they're not catching up, means they're very small, lah, okay? Or their child is very obese, okay, very large for their age. Also not recommended if let's say the drug has very high potency or toxic, lah. Cetirizine is actually quite a relatively safe drug to use. So commonly used in community-based practices because it's easy to apply. So example, your cetirizine. If you're talking about dosing by weight, this is the most common parameters that we use for most of the drugs, okay? Because it's very specific to your age, okay? Usually, the older you get, the larger the weight, okay? But however, nowadays we have children who are either underweight, extremely underweight, or extremely overweight. So in such cases, we will probably need to use the ideal body weight in these children. And when it comes to this ideal body weight in children, there's no formula to calculate. In adults, yes, we do have a formula to calculate, but in children, we are looking at the 50th percentile of their weight. So I'm not sure whether when I say this 50th percentile, I'm not sure whether you can, it reminds you of your health booklet. When your kid last time, when you have this health booklet, you flip, there will be actually be this part that shows your graph. So that will tell you what is your centile when it comes to your own height or your own weight lah. So the ideal body weight is marked as 50th percentile. Okay. Okay, and also that said, if the child is very large size, if you dose based on milligrams per kg, for instance, just make sure that dose does not exceed the maximum single dose for adult. Okay, so if I have like maybe a 50 kilo teenager, okay, giving paracetamol, you can give about 750 milligrams. Okay, that's fine. But if you give 1 gram, it could be too much. Okay, you will not give higher than 1 gram. Okay. Okay, time to take out your calculators and try this out. Okay. So Charlotte's a 2-year-old 15 kg kid, is spiking a fever of 38 degrees. What is the dosing range of oral paracetamol you would recommend? So I already give you a clue. The dose is 10 to 15 milligrams per kg per dose. And we also give you a hint that the strength that we keep is 120 milligrams in 5 mils. So what would be your dosing range in milligrams first? Okay, I will give you about 1 minute to come up with the answer. Okay, I think that's about time. So I hope you got the answer. Oh, wait, you probably can see from my next slide already. Okay, so the answer is 150 milligrams to 225 milligrams every 6 hourly. Very simple. You just use 10 times 15 and 15 times 15. Then you get this range. Okay. Yes, you get a very nice milligrams answer in milligrams. However, if we know that the strength is 120 milligrams per 5 ml, we need to tell the patient, rather the patient's caregiver, what is the accurate volume of medicine that we need to give to the child. Okay, so that's what we call rationalize. Later we'll see. Okay, so let's go to another dosing method. This time around is dosing by body surface area. As I mentioned, this is often given to dose of very potent drugs and high toxicity, for example, your chemotherapy. However, this is the most specific parameter than weight, okay? Because it takes into account of your height as well, not just the weight component. And this is the formula for calculation of body surface area. It's a square root function. take note of this formula because it is important for calculation. Okay, so remember it's weight times height over 3,600 and square root the entire thing. Okay, now another round of practicing. Okay, so take out your calculators and try this out. So let's go through together. What is the dose of prednisolone for 4-year-old boy with nephrotic syndrome who weighs 15 kilograms and is 97 cm tall? So, and for this indication, the dose recommended is in 60 milligrams per meter square per day. Okay. So that means you need to calculate the BSA. So what is the BSA of this child? So if you look at your slides, this is the formula. Punch into your calculator and see what is the BSA. Okay. And then after that, then you will be able to tell you what is the appropriate dose of this child. Okay. And after you have done that, we'll need to find out what is the dose of prednisolone for acute asthma attack. Okay. Now the dose for prednisolone for this particular condition is 1 milligram per kg per day. So let's try this out. Okay. Punch in your calculators and find out what is the answer. All right. If you're done, maybe can someone signal to me whether you have done? Okay, great. Yeah, I see a couple of you already mentioned to me that you're done. Very good. I will move on. Okay, so please double check your calculations. So your BSA 0.636. If you times that, you get 38 milligrams. And for the dose of acute asthma attack, it's very simple. You get the weight times 1 milligram per kg per day. You will get 15 milligrams. Okay, I hope you get the answer. Let's move on. There are more calculations to do. All right, as I mentioned, if your child has a pre-existing condition, as I mentioned, with the liver disease, kidney disease, or even cystic fibrosis, however, there are some very, very limited information in this subgroup of this population. Dosage adjustment are usually extrapolated from adult data, meaning that we kind of like copy what the adult is doing and then we match it to our children. So it could be adjustment of just maybe, for example, halving the dose, okay, or we are increasing the frequency of the drug. So it really depends on the condition. And I'm not testing you on that because it's quite complicated. So it depends on what drug you're talking about, what pre-existing condition you're talking about, and what are the dosage adjustment required. Okay, so just keep this in mind. And we will move on to pediatric formulations. Okay, I think what I've mentioned over here, what I've mentioned just now, kind of like applies to what I'm going through now. So I already mentioned that there's a lack of strength and of medication for children, and that's why we need to know how to split the doses. Okay, splitting of a single unit systems or dissolving it in water. So I already mentioned to you there's a potential for a medication error or administration error. Okay, especially if, let's say, if you dilute it in very, very little amount of diluent, the concentration will be very high. And if, let's say, you missed out on 0.1 or 0.2 ml, a very small volume, it could be associated with large errors because of the high concentration. And also potential complex calculations could confuse the caregiver if we do not counsel properly. So most of the time, if I have such patients, I'll take out a fresh sheet of paper. I'll write down all the calculations for them, and pray that the mom can understand. But most of the time, of course, we will not tell them all the mathematical portion. We'll try to simplify as easy as possible for the mom lah. Okay, so this is a bit of a challenge lah sometimes. And also, as I mentioned, special formulations that should not be crushed. Your enteric-coated tablets, your modified release tablets, or capsule. Okay, so this, I'm not sure, I think probably you have seen this before. Okay, the liquid formulation strengths that is expressed either in weight per volume, either gram per ml or milligram per ml, really mentioned to you just now for paracetamol, or it could also be expressed in the form of percentage, whether it's weight over volume or volume over volume. Okay, so as a pharmacy profession, we need to know how to understand what it means. What does 35% volume over, sorry, 35% weight over volume solution means? Okay, so it basically just means grams or ml in 100 ml of the mixture. Okay, so oh yes, okay, so this is an example of how we convert your volume over, sorry, weight over volume solution into milligram per ml lah. So so 35% just means there is 35 grams, okay, not milligrams, but 35 grams of magnesium sulfate in 100 ml of the solution. So that means if you divide 100 ml from both sides, you get 1 ml equating to 350 milligrams of magnesium sulfate. So if you were to convert it to milligram per ml, it just means 350 milligrams per ml of magnesium sulfate. Okay, so they are equivalent. Okay, so it is also very important that you take note of the conversion of units lah. Okay. All right, I'm gonna give you 5 minutes. I think we probably don't need 5 minutes. You guys are cool. So I guess maybe I give you 3 minutes, 1 minute for each question to write out what is the volume to administer per dose for this formulation. Okay, let's try this out. Now it's 5:18. I shall disturb you again at 5:21. Andrew, I will explain to you later. Let's let everyone finish doing the calculation. Okay. Okay, 1 more minute left. Okay, maybe I'll just take this time to explain to Andrew why do we round down the dose. Okay, in school, in secondary schools, we've been told by teacher they always round up, but in the practice of pediatric medications, we round down because we want to minimize the harm done if there is an error. So that's the main reason lah. I hope that explains to Andrew. You okay with the answer? Okay, great. Okay. Is everyone done with the calculation? Okay, let's go into 521. I should drink water. All right, it's 5:21. Okay, let's move on. Okay, there you go. So please double check your answers and see whether you're okay. So very simple mathematics. I just merely use 144 divided by 24, then I get 6 ml. Augmentin, I use 182 divided by 45.6, the concentration, then I get 4 ml. It's quite straightforward. As for magnesium sulfate, we have already gone through the entire conversion to milligrams per ml. However, in order to calculate it in volume, in 1.75 grams, you have to divide it by the concentration. So I get 5 mils. Okay, I hope everyone can get this answer. Okay, if you have any questions pertaining to this, just state it in the chat box. Later we'll go through again if there's any issue. Oh dear, I have 30 more slides to go. Let's go. All right. Okay, so what if commercial liquid prep formulations are not available? That's where the extemporaneous formulation is required. Okay, it is usually prepared by our pharmacy laboratories. And usually, how do we come up with such recipes? As I mentioned, these formulations are supported by recipes with stability data, meaning when they compound this medication, they will actually have to test to see whether they are stable at different temperatures and at different time frames. Okay, so usually when we get all these recipes, it has been tested and it has been safe when it's being done in a certain manner, when it's being done stored in the correct temperature and with a particular expiry date. Okay, so we have to adhere strictly to this recipe or formula, and any deviation could change the pH or osmolality, which can affect the stability. And however, we already mentioned, it is unfortunate that extemporaneous preparations have much shorter expiry date. Okay, and because of the manpower involved in compounding the formulation, it is usually more expensive. So those are the disadvantages lah. So these are some of the examples of the NUH pharmacy lab preparations. They are mostly, actually almost every single one of them are made using the adult formulation, capsules or tablets. Caffeine, we actually have caffeine powder lah, so we actually just mix it with particular solution to get that. So these are some examples lah. You can tell that expiry date is usually 1 day, 1 month or 2 months, and all of them requires refrigeration. Okay. Okay, so let's say you really cannot find any recipe to make extemporaneous formula. So what can you do? So in our practice, we will ask the parents to crush the tablet in a particular volume of syrup and water, and just take a portion of it. Okay. However, do take note that not all medications can dissolve in water, not all tablets can be crushed, or not all capsules can be opened, and have to check against the manufacturer's recommendation. And whether it's stable in aqueous environment versus other diluent. And usually pharmacists are the ones who get asked whether this can be done or not lah. Okay. Okay, so this is another practice again. Okay, take our calculators again. We can run this through together. Okay, so Melody was prescribed with aspirin 60 milligrams OM as an antiplatelet dosing for Kawasaki disease. Okay, yes, we use antiplatelet medication for Kawasaki to prevent any potential blood clots that can be formed. Okay, so using the proportion method as mentioned, how would you instruct the parents to administer this aspirin? Okay, so in NUH we have 2 different strengths. One is the 100 milligram tablet, the other one is 300 milligram effervescent tablet. So to answer that, usually we'll get the parents to dissolve the tablet, okay, whether it's 100 milligram or 300 milligram, in X amount of water, and what is the corresponding Y ml that the patient will take up. Okay, so I will give you maybe 30 seconds to try this out. Okay, there you go. So very simple. It's really by proportion. So if you have one tablet of aspirin, 100 milligram, I could get and knowing that aspirin 100 milligram actually is a sublingual tablet. It is very, very soluble in water. So I can get the parent to dissolve 100 milligram tablet in 5 ml water and take out a portion of it. So I ask them to take out 3 ml, such that when you take out this 3 ml, it only contains 60 milligrams of aspirin. Similarly, if you're using the 300 milligram tablet, you dissolve in 10 ml water, but you take only 2 ml, a smaller amount. So either of this method works. You will get the same milligram based on the proportion. Okay. All right, more for you to try out. Okay, this gets a bit more complicated. So let's try out more. This time around, I'll give you 1 minute lah, huh? Okay. Okay, time's up. Okay, so 1 minute is up. So let's go through the answers together. So in order to get 1.5 milligrams of the medication using a 10 milligram tablet, I dissolve it in 10 ml, which gives me 1 milligram per ml, and I ask the patient to take 1.5 ml. So that gives you 1.5 milligrams for the propranolol. Okay. For spironolactone, it is 25 milligrams tablet dissolved in 10 ml. That will give me 2.5 milligrams per ml, and I take 0.8 ml. Yeah, correct. Then that will give me 2 milligrams. Okay. For phenoxybenzamine, it's a capsule. Okay. So when I write the instructions on the label, I will say dissolve the contents of the capsule. I don't usually ask them to dissolve the capsule itself. Okay. So just dissolve the contents of the capsule. They are usually powder. Okay. But sometimes they can come in the form of pellets. And if it's in pellets, then this method does not work. Okay. One example is your omeprazole capsule. When you open up your omeprazole capsule, there are small little pellets over there, and they cannot dissolve in water. So you don't use that. You cannot use that method for this. Okay, but for powder, that's fine. Okay, so phenoxybenzamine, 10 milligram capsule, I dissolve in 10 ml and I take 1.8 ml. Then that will give me 1.8 milligrams. Okay, I hope you tried it out and you get the same answers. Okay, now that being said, these numbers are not the gold standard answers. There could be different way of doing it. You could dissolve it in like maybe for example propranolol 10 milligram, you dissolve in 20 ml, then you take 3 ml. That's fine as well. Okay, there's no absolute right or wrong answer as long as the proportion is correct. Okay, I'm left with half an hour with you guys. Okay, so let's quickly run through childhood vaccination. Okay, so vaccines, I think, especially in the COVID situation period right now, we are all hoping to get the COVID vaccine. I don't know when it's going to come out, but hopefully we can get it maybe at least maybe end of the year. It takes a long time to make them. So what are they? They are preparation intended to produce an immunity to a disease by stimulating the production of antibodies. Okay, so antibody is the protein molecule produced to help to get rid of an antigen. Okay, whereas an antigen is the substance that can produce an immune response. Okay, so antigen is the protein that is found on the virus or the bacteria itself. Okay, so so this form of is a form of active immunity, um, and because it's an active immunity, right? There will be memories, immunity memory. It is actually more long lasting, more permanent compared to a passive immunity, and it's supposed to mimic an immune response similar to that produced by a natural infection. So what that means is that vaccines are actually trying to trick the immune system to mount a similar response as if they are having the real deal infection, but without exposure to the real disease itself, without exposure to the complications of the disease itself. So it's more like a trick, lah, okay? Tricking the immune system to produce antibodies that can protect you from the real thing itself. Okay, so however, vaccines, they are different, comes in different shapes and sizes, different forms. There are live attenuated form of viruses, for example, BCG. You probably don't remember it, but you were probably given this when you're born. MMRV, probably given when you're 1 year old. Okay, chickenpox is your varicella. Okay, and OPV is your polio vaccine. This is probably taken when you're in primary 4 or 5, I can't remember. Yeah, but when they're giving you this drop of quite nice tasting liquid, I think, a few drops lah. Okay, it's actually a vaccine. So live attenuated form of virus generally produce a quite long-lasting immunity. In fact, I heard about if let's say if you're vaccinated against BCG, right, you have some form of protection against COVID. But this is not really, we're not sure whether this is proven, but there's some speculation about it. So this is interesting. Okay, then inactivated preparations of virus, IPV, basically they are inactivated inactivated virus, basically, and usually because they're inactivated, they require multiple doses to make sure they maintain the immunity, sometimes requiring booster shots. Okay, or it could be not the organism itself, but certain parts of the microorganism or the toxins or the detoxified exotoxins. Okay, because when this is inserted into the body, right, the immune system cannot really recognize whether they're real thing or not. They will still mount the same immune response, producing the same antibodies. So yeah, so they could be part of a virus, okay, rather than the full virus. So this is a summary. Okay, live attenuated virus will be example will be your rotavirus. It is a live virus, but attenuated means it's not supposed to cause disease. Okay, they are weakened. For bacterial live vaccines will be your BCG, as mentioned. For inactivated vaccines, inactivated whole virus will be your polio vaccines, the injection version, or pertussis, the bacterial version, or it could be a fraction of a virus. Okay, for example, your Hep B, or fraction of a bacteria with your diphtheria, or it could be the polysaccharide coating of the virus. Okay, so for example, your pneumococcal, or could be a combination of different parts of the virus, which is found in the human papilloma virus, like HPV. Okay, so these are the various classifications of vaccines. Yes, and this is the National Childhood Immunization Schedule in Singapore. We follow this rather closely for our children. Typically, they are done in polyclinics lah. Okay, so they'll try to figure out how to give the vaccine, because different vaccine you have different schedule, but to make sure that they catch up with the vaccine. So please don't memorize this, okay? But it will be important to know how to interpret the schedule lah, okay? Right. So some of the general, okay, sorry. When I say memorize, don't memorize the schedule, but do know what are the vaccines that's inside the childhood immunization schedule, okay? Like whether you know whether polio virus is inside the schedule or not, or whether hepatitis B is inside the schedule or not, okay? Hint. Now, okay, so coming back to the general recommendations of vaccine, If let's say you have severe allergy, severe allergy means urticaria, angioedema, wheezing, hypotension, shock. These are probably anaphylaxis, and these are absolute permanent contraindications. Means if you have any of these symptoms after getting the vaccine, you should not be taking the vaccine anymore. Okay. However, there's also this thing called temporary contraindication. If let's say the patient is under immunosuppression, uh, uh, or maybe pregnant, okay, certain vaccines may not apply. For example, live vaccines should not be given to a pregnant lady, okay. Or temporary precaution. All vaccines should be delayed when there's some moderate to severe illness. So meaning that if let's say you're sick, you're having fever, I don't think I want to mess up your immune system by giving you more vaccines, okay? And I don't think you'll get a good immune response because your immune system is busy fighting an infection. So we will usually delay the vaccine if the patient is sick. Okay, moderate to severe illness. So live vaccines and antibody, yes, do take note that there are some interaction. If you are giving a live vaccine, okay, you should not be giving any medication that contains antibody. So some of the medications that contain antibody includes plasma product, okay. It could be your IVIG. IVIG is intravenous immunoglobulin, okay. We give that to Kawasaki patients, okay. So if you're giving a live vaccine, you cannot give this this kind of blood products to the patient. You have to wait a couple of months before giving any live vaccines because it will interact with the vaccine, causing the vaccine to be less efficacious. Okay. Yep. So yes. Then use of live vaccines, for example, BCG, MMR, contraindicated in immune suppressed patient because the patient has a suppressed immune system. If you give live vaccine, there is a potential that the live vaccine can infect the patient. Okay, pregnancy we don't give as well. Okay, because there could be harm that could be done to the unborn child. Okay. So if the patient is going through chemotherapy, we will want the patient to be fully immunized before the chemotherapy wipe away all the important white blood cells that is involved in mounting the immune response. So give at least 2 weeks. And if there's a pause of stopping of chemotherapy or the use of steroid, then you have to space another 3 months, okay, to let your immune system recover so that when you give vaccines, they can still mount the same response, okay? But this is more particular to live vaccines lah. If you're using inactivated vaccines or killed vaccines, usually it doesn't really cause much harm to an immunocompromised patient. However, you need to revaccinate again if there is a cessation of treatment of the above treatment that we talked about, like chemotherapy or corticosteroids. Okay. Okay, then there's another question, whether 2 different vaccines can be given at the same time. So if we have 2 different live vaccines given on the same day and different sites, they are actually okay. Okay, most of them are okay. But if you don't give them together on the same day, then you should give them 4 weeks apart. Okay. You cannot give vaccine number A that's live and you give vaccine number B that is also live 2 weeks later. It might mess up the immune response. Okay, so this is what is recommended. And however, there are some exceptions. Like for example, live oral vaccines doesn't really matter. Okay, so this is a general rule that we practice lah. Okay. And however, there's also other combinations of vaccines, whether live and inactivated. So generally, you can give both a live and inactivated vaccine together with no issues. Okay, they should not interact. That it does not decrease any antibody response or increase adverse effects. So live and non-live vaccine can be given together. Okay, and if it's a live and a live, you either give them together or you space them at least 4 weeks apart. Okay. Okay, interval between doses of the same vaccine. So Okay, so there's a principle. If you're using the same vaccine, you have to make sure that you have to give enough time for the body to mount an immune response. Okay, so if let's say if you decrease the interval between doses of the same vaccine, it might interfere with the antibody response because you're not giving enough time for the body to mount the immune response. Okay, so vaccine doses should not be administered at intervals less than the minimum interval. Okay, in general, most of the time, vaccines, the minimum interval is about 4 weeks in general. Okay, however, there are exceptions. So that means if I give the vaccine vaccine A on this particular day, usually I have to wait for 4 weeks later to give the second dose of vaccine A. Okay, if I give it 2 weeks later, it might not mount the optimal antibody response. Okay, so there has to be a minimum interval, and usually this is 4 weeks. Okay, if let's say you are increasing the interval between the doses of the same vaccine, it usually doesn't matter. It does not diminish the effectiveness of the vaccine. What I mean is, for example, if you give vaccine A on today, uh, usually you by right next month, 4 weeks later, you're due for the vaccine, but I missed the appointment. Okay, I come back again 2 weeks later. I take the vaccine at that point in time. Is it still effective? Yes, it is still effective because the interval, although it's increased, it should not affect the effectiveness of the vaccine. Okay, so that's why we always look at the minimum interval of vaccines. And vaccines doses should not be administered earlier than the minimum age. Now, in children, there's always a minimum age. As mentioned before, when you're too young, okay, your immune system is immature. You're unable to produce sufficient produce sufficient antibodies when you give them the vaccine. So, certain vaccines are recommended only at certain age minimum. So, if let's say, but sometimes it's very difficult to count the days. Okay, if you were to get to the ground and do it on the spot, like, oh, I have to look at the calendar. Dose number no dose vaccine A dose number 1 is done on the 1st of October. When is the next day I can really do it? Then you have to fix the schedule with the appointment with the doctor in the clinic. Is the clinic open? Are you free that day? So these are the real life situation. So in general, if let's say they give this grace period they call this the grace period. So the grace period is actually 4 days. So what does it mean? So it recommends that doses given up to 4 days before the minimum interval or minimum age is counted as valid. Okay, what do I mean? Later we'll do a quick quiz and to find out what does this statement mean. Okay, oh, actually it's here. So yes, so let's just practice this. Okay, so Jack is a 7-week-old boy. Okay, he's due for his rotavirus vaccination. Okay, so given that the minimum interval between the 2 doses of rotavirus is 4 weeks, and if my dose number 1 falls on 1st of October, as you can see from here, dose number 1 is on 1st of October, which is the ideal earliest day should the patient get his dose number 2? Okay, so please lock down your answers. It is mentioned that the minimum interval between the 2 doses is 4 weeks. So which day is the ideal day that you should get the vaccine? Okay, 5, 4, 3, 2, 1. Lock down your answer. Yes, okay. So the ideal situation on the 28th of October, that is on the 28 days, it's actually on the 28 days, that is the day, that is the ideal day where you can give the vaccine. Okay? It doesn't really matter what time you give the vaccine, as long as it's on the same day, okay? To minimize confusion in the logistics. Okay, now, next question. If Jack comes back on the 24th of October to get her second dose, is this considered valid? So we know that 28 is the ideal day, but instead I come 4 days before. So is this considered valid? Okay, let's try it. 5, 4, 3, 2, 1. Yes, it's valid because it is within the grace period of 4 days or less before the minimum interval. Okay, so I do it on the day 24 days. It is still within that grace period, so that's why it is still considered valid. Okay, and then Jack doesn't have to redo the entire vaccination. Okay. Okay, Ken, and these are some of the examples of the vaccines that's available in NUH. Just a glance through, just take note that which one are the live vaccines, which one are not live vaccines. It's quite easy to remember. Just remember the live ones, then the rest is all inactivated. Your BCG is live, your polio is live, your MMR is live, your rotavirus is live, and your varicella is live. Varicella is your chickenpox. Okay, then the rest is all inactivated. Remember only the live ones. All right. Okay, and I'm gonna breeze through this issue on pediatric poisoning and management lah. Okay, so for pediatric poisoning, we're almost finishing the lessons anyway. Okay, so for pediatric poisoning, infants as less than 1 year old represent only 5% of all exposures. That's because when you are less than 1 year old, you are not able to walk fast, grab so easily. Okay, but when you're 1 to 6 year old, you can start walking, you can start crawling, and you can start grabbing a lot of things. And because of that, and also coupled with the curious nature, they're always constantly exploring the environment, and they always like to put things into the mouth. Okay, so the chances of getting poisoning is actually much higher. Okay, that's why half of all the poisoning exposure happen in this group of patients of 1 to 6 year old. And if for older children and teens, when they do poisoning, it's usually intentional, probably because of psychological issues, psychiatric issues, or could be because of abuse or misuse. Okay, so that is the nature of the classification of pediatric poisoning. So most of them, they do not result in very, very serious harms. However, some substance that is listed over here, for example, may cause significant toxicity in minute amounts. So where did they get all this medication from? It could be medications that belongs to their parents, and they just overdose on these medications, whether intentional or unintentional, depending on the age group and the intent. So these are some of the important ones that could cause significant harm lah. So in general, if the patient were to take, what are some of the common symptoms in general when patient is experiencing poisoning? So frequently you see seizures, okay, and you'll be very drowsy or your mental state is totally altered. Pupils could be increased or decreased depending on what you ingest. And oral secretions, again, depending on what you ingest. If you're ingesting an anticholinergic, your secretion will be very, very little. Or you ingested a cholinergic drug, you'll be very increased or no change. Respiration, if you ingested a lot of morphine or opioids, your respiratory rate would drop. Or you could be breathing very, very fast, depending on what you ingest. Most of the time, if you overdose on antihypertensive, of course, you get hypotension. But if you overdose on, I don't know, maybe let's say Clarinase, okay, or Zyrtec D, maybe you take 100 tablets of it. There is a pseudoephedrine inside there, which can cause hypertension. So it could bring up your blood pressure. Heart rate, again, depends on what you're ingested. If you ingested a lot of antibiotics that can prolong your QT, then you can cause a arrhythmia, okay, your heart beating irregularly. Body temperature, it could increase your temperature or it can decrease your body temperature as well. Lung secretion, GM, motility, sweat, depends. Okay, so these are some of the symptoms that we look out, okay, when we look at poisoning. So of course, when it comes to poisoning, right, most important, especially when they rush into the ICU, we must make sure the three most basic parameters are taken care of. It will be your airway, your breathing, your circulation. So we'll want to make sure that they are all taken care of. If you're not breathing, if your airway is stuck, you have to be intubated. Okay. Circulation wise, if your blood is not moving in you, then your blood pressure is low, then probably you might be started on medications, inotropes, or vasopressors to help to keep your circulation ongoing. That'll be in ICU already. Okay. And we also need to know what are the poisonous substances that they have ingested. Okay, if you are able to discover the poisoning very early, decontamination is the key, where we give activated charcoal. We use that because we know that charcoal is a very good agent that can help to absorb with a D, the culprit drug that could be causing the poisoning. Okay. However, if it's discovered too late, if the drug is already absorbed into the body, there's nothing much you can do with activated charcoal. So not useful for drugs that cannot be absorbed. For example, your iron, lithium, or alcohol. Okay, they're readily absorbed. Another issue is another way is to enhance the elimination, whether you give gastric lavage, like basically washing your stomach, or you do dialysis, you wash out the drug through the blood dialysis machine, or you use a whole bowel irrigation. These are some of the possible methods of getting rid of the drug that causes poisoning. So these are some measures. So there are selected specific antidotes for specific agents. So it is, in my practice, it's very common to see paracetamol poisoning. Okay, so in America it's called acetaminophen. In UK it's called paracetamol. So if we see paracetamol poisoning, the choice of drug, the antidote used is N-acetylcysteine, which is actually your flumasil. Okay, which we use it for as a mucolytic for dissolving phlegm. If you're overdosed with benzodiazepines, for maybe diazepam, midazolam, lorazepam, there are agents to reverse it, which is your flumazenil, okay, which is an antagonist for your to the benzodiazepines. And if you're on beta blocker or calcium channel blocker, you can use glucagon. Or if you overdose on morphine or overdose on fentanyl, at least you have an naloxone to reverse it. So these are drugs with specific antidotes, and it's important to remember them lah. Okay. So I've come to the last slide of my presentation. So in summary, I'm sure after almost 2 hours of lecture, you know that children is not just small adult. They are diverse group of patients and requires very, very customized care. Okay, a lot of attention has to be given to them. And in view of the complex nature of your drugs, there is a high risk of error due to low margin of error. And if you understand the developmental PK principles, you can dose your drugs better in your children, and you can monitor them much better lah. Okay, so these are my references, and thank you very much. Do you guys have any questions? Feel free to post it. Hi, okay, so Miao Ying, Miss Ying Song, right? Okay, so why is 4 weeks not after 29 days? Okay, because I include day number 1. So you see, sometimes there's this confusion in this calendaring issue. So if you put as 29, it's also not wrong. It is still 4 weeks. That's why this 4-day grace period is it's important to get rid of this kind of confusion. Because some people, if they get the vaccination at night, then can I consider still as you know, the timing, the hours, so it can be a bit difficult to ascertain. So that's why there's this 4 day that you can play around. But knowing the principle behind vaccine, it is important that we try to drag the interval, increase the interval rather than giving it too soon. So it's better to be late than to be too early in this case. So this 28 is just a guide lah. And this is what I practice as well. Okay, aside from Yingso, any more questions? Any more questions? So we will always take into account a day of vaccination. Okay, this is my practice. I'll take into account. Of course, it's easier to calculate. And every time when you do vaccination schedule, it is very important that you take out a calendar, because without looking at the calendar, it's very difficult to visualize. All right, I will be here for another maybe 2 more minutes. Any more questions? Anyway, have you guys submitted, completed the quiz, the pit stop questions? And I think you have to submit, right? If I'm not wrong, I haven't seen the real thing yet. But anyway, just make sure you submit lah, because Ms. Yichuan will be looking at it and will be marking as well. For exams, just make sure you look through my slides. And if you're not sure, you can re-listen to this lecture. And if you have any further questions, I think my email is there. You can feel free to email me. I'll try my best to answer you. And if no more questions, I don't see any more questions, I shall release you guys. Okay. Don't have my email, really. My email is on the, let me see. Oh yeah, sorry. I didn't give you my email. Okay, let me, okay, my email, let me just put this inside here. And what? Don't worry, I will ask Ms. Yichuan to also send you guys the email. This is my email. Please take down should you have. So itashimashite. All right. Thank you very much, guys. Bye-bye. Stop recording. Will be safe in Yan Poly's first Google Drive. Stop recording.